My name is Dr. Kumar Rudra, and I am one of the geriatricians or consultant in health care of the elderly people, also a physician, of course, and I belong to a team of consultant geriatricians of nearly 8 of us. So it's a very well supported department in this hospital. HCOOP, as in healthcare of older people, which was previously called geriatric medicine, of course. And we have general internal medicine, but made up of all the subspecialties across the board, which is, say, for instance, endocrinology, gastroenterology, cardiology, respiratory medicine, rheumatology. And they all play a part in the acute medical rota. Elderly care and general medicine does ward-based. So to give you an example, Dr. Jenkinson and myself are based in Deal Ward. So any patient that comes to Deal Ward as an elderly patient will get allocated to either of us. But also we will have the endocrinologist, for instance, Dr. Stoney Joseph and Dr. Chris McGettigan, placed in that ward. So their patients allocated to them will arrive at that ward. So they're responsible for those patients. However, general medicine and elderly care medicine is also providing the specialist input into patients elsewhere. So there could be a patient, elderly and frail, in a surgical ward where we will be providing it, the help. But of course, if it is hip fracture or stroke, there are dedicated wards that are specifically addressing those patients.
I would arrive on the ward at 8:30 or 9 o'clock, it depends on which consultant. We have 2 consultants that we work for. We would do a ward round, see any new patients in particular, and create plans, and then the rest of the morning usually is spent working through the plans, so usually prioritising, making sure bloods are taken, any scans are ordered, any communication with other teams is prioritised in order that things can move along over the course of the day. Often at around lunchtime there's a good programme of teaching, and then in the afternoon we might be following up on results from blood tests or other investigations, liaising with consultants, often speaking with family members to update after the ward rounds have taken place. The families normally visit in the afternoon, and preparing discharges or possibly referral letters with discharges, so the patients can go home in the evening or the following day.
There's great opportunities for us after the consultants are done their acute round for the juniors to see patients by themselves and gain a lot of experience in coming up their own management plans, seeing patients by themselves, gaining some level of independence in a very well supported system where the consultants are always approachable, always reachable if any problems come up. And on specific days we'd be given plenty of opportunity to go to clinic as well, where we get to see patients by ourselves, our own rooms, and come up with our management plans and have the consultant there support us, give us their input, and we get to see the outcomes immediately there and then, which is very rewarding.
My name is Dr. Farina Yasser. I'm the specialty registrar here in the orthogeriatrics. So this is basically a Bishopston ward, and this is an orthogeriatric ward. I actually help my junior doctors in understanding what orthogeriatric is, and how we deal with the bone protection and how we deal with the patients coming in with the fractured neck of femur and falls.
My name is Dr. Mohammed Khatta. I'm one of the Foundation Year 2 doctors working in geriatric medicine in the subspecialty of orthogeriatrics. And what our role is really the comprehensive assessment of the elderly patient when they come in with a neck of femur fracture or any other fragility fracture. The firm really gives you a good insight into comprehensive geriatric assessment and the big issues in geriatrics, which are falls, frailty and fragility fractures.
on-call here at Margate is divided into two teams, the hot on-call, the cold on-call. The hot team manage all the patients who come in through the front door and is made up of the registrar, the 2 senior house officers, and the 1 Foundation Year 1 doctor. The rest of the hospital during out-of-hour periods on the weekends are attended to by the cold team, and that consists of the cold registrar and the cold Foundation Year 1 doctor. During the nights, it's up to the hot team to share cold responsibilities.
The hot on calls are working with the team in A&E and in the acute ward, which is our CDU, and they on the weekends they would be helping mainly in CDU and making sure all the patients are stable there. During the week we have the opportunity really to go to A&E and help clerk in patients there. We sort of do the whole procedure, we clerk them in, we order all the investigations, and we run it past the registrar or the consultant on call on that day, so we can work out a proper management plan. So it's very well supported, it's a really nice team atmosphere, and we can normally end up ordering pizza in the evening, but it is quite a long shift from sort of 9 till 9, and that you would do that sort of 2 days during the week, then you would do the weekend, and then 2 or 3 days the following week as well. The cold on call, during the week you're sort of on your own between 5 and 9, and you're in charge of all the wards, all the medical wards, so anyone that goes off sick you'll be looking after them, or some of your colleagues might hand over jobs to chase from during the day, so you would be looking after them and chasing those jobs during the week. On the weekend you also get a registrar to help you out during working hours, so from 9 till 5, and they're normally a very good base to help you with all your management of the patients. And then in the evening it's similar to during the week when you're sort of on your own again, looking after all the sick patients.
I take great pride about QEQM's postgraduate as well as undergraduate education, and certainly being a lead in postgraduate medicine as a college tutor, I can say that it is extremely well organized and naturally very well liked by both senior and junior doctors. So it's a very structured, disciplined education system here in QEQM. So for instance, we have every week, every Tuesday, the elderly care medicine as well as general medicine coming along into what is known as a geriatric postgraduate tutorial event. So that is structured, that is protected. Foundation year doctors, co-trainees, registrars from across the discipline and in elderly care, they attend. Junior doctors present cases, and sometimes senior doctors present cases as well, and that is where they get their feedbacks about their teaching skills and how they develop that.
Lunch times we normally have teaching, so F1s get teaching every Monday and Wednesday, which is great. We have a mix of people from core trainees up to consultants who teach us, and some of the nurses, the nurse practitioners are really good at teaching us as well. So that's on Monday and Wednesday, and then we've got opportunities to go to some of the other teachings on the other days, which is they're always quite good. Always quite a good turnout as well, so we can go to the CMT teaching, which is the core trainee teaching, on Fridays, grand rounds where we have guest speakers sometimes coming in, or just interesting cases that have happened in the hospital, which is something we can all learn about, and is well attended by the consultants as well, so we can have quite good discussions over these cases. It helps all of our development really.
The core medical trainees like myself get regular teaching on the Fridays. We also have a very unique tradition here of the medical half day, which is something that Dr. Rudra came up with. It's very unique to Margate, where once a month everybody in the hospital is freed up for half a day to attend a full afternoon of teaching. And Dr. Rudra would often invite speakers from other hospitals and various academic institutions in London to come and speak.
We are always looking into new ways of delivering education in postgraduate medicine. We have decided to actually include sort of journal club type presentations, which is an interesting and an important skill to learn, for doctors to learn how to critique research papers. The feedback in this hospital in particular is a constant theme. Feedbacks are happening right at the front end of the hospital as an acute take. So as soon as a trainee has clerked a patient and they present the case in a post-take ward round, part of that education is actually giving the feedback to the trainee, which is happening then and there. But also, if a trainee, for instance, has presented in a postgraduate medical grand round, I actually write written feedbacks to them. And some of my colleagues do the same as well. And likewise, in the hospital, in the day-to-day running of the hospital, in the wards, they get constant feedback about their clinical input, how things could have been better, or where things have been better, acknowledging that the hard work that they're doing.
The hospital is quite a small hospital, and over the first few months, you almost get to know everyone in the hospital. So you always have a registrar on call, and by the end of those 2-3 months, you know them well. They're sort of become one of your friends, and so I have no qualms about asking any of the registrars for help, which is great. There's normally a consultant around as well, and they're really, really friendly here. And so you can call them up on their mobile, and they are great. They always offer good advice, and you've always got your other colleagues as well. You've got other F1s around just for a bit of support. The nurses are very knowledgeable as well, very handy if you're in a bit of a tricky situation, and they can always help out. So it is well supported.
There's a lot of cross-covering between teams, so juniors will help each other out in a ward-based way. So on the ward that I work on at the moment, we have many different teams, but really within 2 different specialties. So we have rheumatology and acute medicine, which is what I'm working in, and the care of the elderly, so HCOOP. And when the HCOOP teams are very well stocked, but I'm on my own, sometimes one of the juniors will help me, and vice versa. If there's not a great patient load on my side, I'm more than happy to help them.
MDT is an integral part of the process of looking after patients with complex physiology. It is not just about fixing a disease process. It's a holistic process, and more so in elderly care, and that is where the term has come into existence that we are aware of now is CGA, Comprehensive Geriatric Assessment, where the occupational therapist, the pharmacist, the discharge coordinator, the nurses, they're all coming together. All the information that is vitally sitting there is flowing beautifully into that unit, and that results in a very effective, efficient discharge planning. And naturally, the best outcome for the patient.
It's really quite a small hospital, so it's great community spirit. I've got friends from the nurses to the porters up to the consultants, and quite a lot of them, we go out for meals quite regularly from all walks of life and everyone from the different healthcare professions. It's a really nice atmosphere here, and I think that's the main thing, because you're always going to have the support, and you've got people you can contact it when you are struggling or if you need any help.
There is no question in my mind, not just because I'm working here, that this is the best hospital to work in. Firstly, of course, the beauty of this part of the country and its landscapes and what it has on offer. Plus, of course, so it's a nice place to live in, but in addition to that, the hospital itself actually fosters a beautiful culture of friendship. It's a very friendly hospital. Everybody is there to help. And there is, a vast amount of senior expertise across elderly care and general medicine. And that is on offer. And if I was a trainee, I would definitely come along to grab that opportunity and, learn how to be an expert in any field of my choice.